afternoon, ladies and gentlemen. This is Dr. Rajeev Aggarwal. Today I'm talking about residual lipid risk beyond LDL. What are the recent evidences? The topic is very contentious because there are so many controversies regarding lipid management beyond LDL. So I'll try to highlight what is the current literature position and how we are placed. This is my very favorite slide. I keep saying that atherosclerosis never sleeps. It creeps while you sleep. And that is another perspective of atherosclerosis, is that it is relentlessly progressive disease over a period of time, and lipid lowering therapy, primarily LDL lowering therapy, we do extremely well for our patient, but still there is a residual risk. And that is why the need for this topic, that what we can do beyond LDL reduction at the moment. All of you must have seen this slide many times. That is how we look at secondary prevention. At extreme left, we have LDL-C reduction paradigm. On extreme right, we have different way of treating diabetes by SGLT2 inhibitors and GLP-1. I have no hesitation in saying that these two extremes are the most established pillars of secondary prevention. We have residual inflammatory risk, which is an accepted risk factor, but tools are very limited. Residual thrombotic risk, where tools are there in terms of prolonged dual antiplatelet therapy or low dose rivaroxaban. As far as the lipid is concerned, we have two pillars: TG risk reduction and LPA reduction. So my topic confines me to these two pillars, how we are positioned on these two fronts. This is a very provocative, controversial, but very insightful slide, which I keep showing. Is triglyceride correction is a cosmetic correction. So are positively associated with CV risk in people with diabetes. We understand that elevated remnant cholesterol, plasma TGs, and cardiovascular and non-cardiovascular mortality is important, because chylomicron and triglyceride, they go hand in hand, and they are important risk factors for atherosclerosis. CV mortality and other mortality is related with chylomicron remnants, but not the cancer mortality. This is in a nutshell all TG lowering trials so far. Many of you must have seen the presentation of Field and Accord. Field was again a statistically non-significant trial, and the total mortality increased by 19%, but insignificantly. Accord lipid decreased mortality insignificantly by 9%. So none of the trials from fenofibrate has shown mortality reduction, except a subgroup analysis showing CV risk reduction in some specific subgroups. So historically, TG lowering is not giving any outcome benefit. Prominent was a study which was weighted a lot because it was specifically directed to triglyceride. The temafibrate was used, 10,000 participants, 24 countries. Unfortunately, last year it died because it increased the LDL-C level, whereas ApoB100 was unchanged, and the study was withdrawn and presented as a neutral study. It was not harmful, but it was a neutral study. And it is a summary that ApoB was not reduced and TG was marginally increased, and that was the there was no outcome benefit. There was another drug which was from Pfizer, buprenorphine, specifically for TG lowering, and this drug also died and the trial was abandoned in January last year. So in high risk crime with secondary prevention patient where you have achieved LDL goal, the recommendation of TG lowering is 2BC. That means it is a very weak indication. And this is a recent editorial, fibrates, one more lost paradise in lipid management. So ladies and gentlemen, TG reduction is not really paying in terms of outcome benefit. And I often say the pro-TG community keeps on manipulating data, torture the data and try to justify its usage. In summary, I'll repeat, TG are very important atherogenic particles, but they are not, when treated, result in outcome benefit. So triglyceride at the moment is a risk marker, not a risk factor. Many of you must be aware about EPA reduce it trial. Many of you confuse it as a TG lowering trial. It's a vascular trial, not a TG lowering trial. It showed enormous advantage. Primary outcome benefit was there. Secondary outcome benefit was there. Mortality reduction was there. Here the EPA was used 2 grams twice a day. And there was relative risk reduction of 25%. Absolute risk reduction was 4.8%. NNT was 21%. And TGs were marginally reduced by 20%. CRP was reduced by 40%. And as you know, the entry criteria of high TG and low TG did not make any difference in outcome benefit. So this trial was used, in this trial, TGs were used as a risk marker, and you walk into the trial, but outcomes were not related to TG level. The way we talk, if you have higher LDL, you have higher benefit. So that point was not taken out of this study. That TG was a risk marker, but it was not related to outcome benefit. There were many theories that how the benefits were achieved. The mineral oil, which was used as a placebo, has fallen into controversy. I'll dwell upon that. There are various mechanistic pathways where you understand it is primarily a vascular drug rather than a TG lowering drug. And this is a wonderful slide, if you can retain it, that anti-arrhythmic property, TG lowering, heart rate lowering, BP lowering, anti-thrombosis. So there are various mechanistic pathways and there are time frames how they are being affected by EPA. This is Stephen Nissen last year who talked that the Reduce It trial was positive because the placebo was not placebo. It was a negative placebo. It was not a neutral placebo. So this trial has not gone into 1A recommendation at the moment. It is just landing at 2A and fallen into controversy because of mineral oil negativity. And various inflammatory markers are there, which are increased like CRP, IL-6, IL-B. They're increased by placebo. So naturally, the EPA got an advantage over placebo, and the negative placebo made this trial probably very strong. Amarin, which made this drug, are losing market, and they have lost already 90% of the EPA market in United States. So this trial, although looked very positive, a couple of years back, is finding its place, and people are finding it difficult to digest in view of this trial. I say Koch's postulate, you are all aware in terms of tuberculosis. I have tried to apply them. TGs are atherogenic. TGs can be effectively reduced. TG reduction do not translate into outcome benefit. That is the problem. LPA is another molecule which you must understand that it is atherogenic and thrombotic. LPA is a risk amplifier. Whatever risk you have, if you have high LPA, it amplifies the risk. It is associated with aortic valve calcification also. We have a drug called pelacarsen for LPA, and it drastically reduces LPA level. And this is the couple of drugs, pelacarsen, olpasiran, and SL360, which are coming up to reduce LPA. But mind it, there is no outcome trial which shows that LPA reduction reduces mortality. So LPA story is high LPA causes atherosclerosis. LPA can be effectively reduced by drugs. LPA reduction reduces atherosclerosis is unknown. So that is a question mark. What is the current perspective? Out of all the risk factors, LDL reduction is the most important risk reduction. And that is what we focus, that in patients who have high TG, high LPA, probably we have to be more aggressive on LDL lowering, and Cox postulate can easily be translated on LDL lowering. So I'll say once you find high TG at the moment, high LPA, these patients need to be treated with different drugs like oral PCSK9, CTP inhibitor, which are coming up in a big way, and you can have another LDL reduction to the tune of about 45%. And then we have CRISPR technologies, which can result in reduction, deletion of gene, and these the problem can be taken forever. This is once and done approach. So this is the future of lipidology. So I'll say LDL today is a clear-cut winner. HDL is loser. Triglycerides are losing. LPA is running in trials, and we do not know the outcome. That is how I look at it. So my presentation is more like CAST, courage, revive, strength, and prominent, which are negative trials. So my presentation is negative. I'm trying to show you that these ways are not working at the moment. Lipidology at the moment is LDL lowering. Let us be artery healers. Let us be taking atherosclerosis, not stenosis. And do not forget that walking is the man's best medicine. Thank you very much.